A new treatment for patients is dropping soon. Remember the name, Baxfendy, also known as Baxdrostat. Baxfendy is coming soon. Baxfendy is almost here. Stay connected to Baxfendy. Visit baxfendyhcp.com. That's baxfendyhcp.com. Sign up to receive upcoming updates on Baxfendy.
Worldwide, cardiovascular disease affects the lives of hundreds of millions. Dedicated cardio nerds everywhere are working hard to fight this global epidemic. These are their stories.
Hey, cardio nerds. Today we are going to delve into the superpowers of SGLT2 inhibitors, this time focusing on their role in CTRCD. My name is Natalie Marrero, PGY3 in internal medicine at the University of Miami and House Chief for House Taussig. I am thrilled to introduce one of our Academy Fellows, Shivani Reddy, PGY2 in internal medicine at Baylor University Medical Center, and our podcast lead for this episode.
Thank you so much, Natalie. I am so excited for our discussion on this very important topic. Before we delve deeper, I have the great pleasure of introducing another House Taussig Fellow, Dr. Rebecca S. Steinberg, who's a first-year cardiology fellow at Duke and our review article lead.
Thank you, Shivani. So thrilled to be back at our CardioNerds Cardio-oncology clinic. I have the great honor of welcoming Dr. Manu Murali Mysore, who is an expert in cardio-oncology. Dr. Mysore is an assistant professor and co-director of the cardio-oncology division at the University of Maryland Medical Center. He's an integral part of a multidisciplinary collaboration between hematologists and oncologists at the NCI-designated Marlene and Stewart Greenbaum Comprehensive Cancer Center and the University of Maryland Heart and Vascular Team. Prior to this, Dr. Mysore attended medical school at Louisiana State University, went on to complete his internal medicine residency at the University of Virginia and cardiovascular disease fellowship at the University of Maryland. Welcome to the podcast, Dr. Mysore.
Thank you, Rebecca, and everyone for the kind introduction. It's my true pleasure to come and talk about a topic and field of passion, per se, in cardio-oncology. Excited and very thrilled to be here today.
Thank you so much for joining us today, Dr. Mysore. We're also excited to learn all about SGLT2 inhibitors and their role in cardio-oncology from you. So without any further ado, let's dive in. We've got a very busy day today at the CardioNerds Cardio-oncology Clinic, as usual. To start out, we've got our first patient, who is Miss Adriana Myson, a 42-year-old female with newly diagnosed ER-positive, PR-positive, and HER2-negative stage 2 breast cancer, status post-lumpectomy and radiation therapy. She has a history of paroxysmal AFib on Eliquis, heart failure with preserved ejection fraction secondary to non-ischemic cardiomyopathy, hypertension, type 2 diabetes, and obesity with a BMI of 31. She's scheduled to begin a chemotherapy regimen involving anthracyclines very soon. She has no prior smoking history. She's concerned about the red devil chemotherapy agent, aka doxorubicin, and its impact on her heart. Her baseline values are as follows: troponin of 10, NT-proBNP 900, and LV ejection fraction 55%. Certainly, minimizing cancer therapy-related cardiovascular toxicity is crucial to maximizing the efficacy of chemotherapy as well as long-term survival for Ms. Adriana Myson. Dr. Mysore, for our listeners who may be new to this field, could you please describe how we currently define and classify CTRCD, or cancer therapy-related cardiac dysfunction?
That's a great question. There's definitely a lot to say. So cancer therapy-related cardiac dysfunction, or CTRCD, as mentioned, has been defined in several ways over the decades, per se. In the early 1990s, it was only recognized when patients developed heart failure or just a noticeable drop in ejection fraction. However, over time, the definition has evolved to detecting subclinical injury using tools such as global longitudinal strain and other cardiac biomarkers, allowing clinicians to catch heart damage before symptoms appear. Today, the European Society of Cardiology has provided a graded comprehensive framework that defines CTRCD from mild asymptomatic changes on imaging or labs to severe symptomatic heart failure, reflecting our ability to identify and to manage cardiotoxicity early and proactively. One of the major points of CTRCD involves a historical definition of types of CTRCD, including type 1 dose-dependent irreversible injury, such as from agents as anthracyclines, and type 2 reversible dysfunction from agents such as Herceptins or trastuzumab.
Thank you so much. It's really helpful to hear the historic context and framework and understand the limitations of old frameworks. Dr. Mysore, how do we diagnose CTRCD?
So there's 2 ways that I look at it. There's the asymptomatic side and there's symptomatic side of the definition. So from the asymptomatic side, and a lot of this is pulled in from recent guidelines such as ESC 2022 and ICOS, is defining as mild when the LV ejection fraction is greater than 50%, but there is relative new decline in global longitudinal strain by 15% or more, or with a subsequent rise in biomarkers. Moderate if the LVEF is between 40 and 49%, and or a reduction in ejection fraction by 10 percentage points or more. And severe, of course, if there is a reduced LV ejection fraction to 40% or less. So those are how they have defined CTRCD from an asymptomatic side. And there is also symptomatic CTRCD, where there are signs and symptoms of heart failure with NYHA classifications 2 or greater, with corresponding imaging and biomarker abnormalities, and severity, of course, graded by heart failure class, as mentioned, and not just purely by the ejection fraction alone.
Thank you for explaining how we use the severities based on EF changes to define asymptomatic cases, and also the role that symptoms play in defining CTRCD. Moving on, how would you recommend that we monitor our patient for the possible development of CTRCD?
Great question. So for Miss Adriamycin, who's about to start anthracycline-based chemotherapy, careful cardiac monitoring is fundamental or key to minimizing cancer therapy-related cardiovascular toxicity or dysfunction. Baseline assessment shows a preserved EF at 55%, a mildly elevated pro-NT-BNP at 900, and a low-level troponin at 10, reflecting some underlying HFpEF and other cardiovascular risk factors. According to cardio-oncology guidelines, we'd continue with serial monitoring using LV ejection fraction and global longitudinal strain by echocardiography, likely after every couple cycles, and troponin and pro-NT-BNP at each chemotherapy cycle, if possible, from both an oncology and cardiology perspective, as well as close attention to symptoms such as dyspnea or fatigue. High-risk patients like her, those with HFpEF, hypertension, diabetes, and obesity, may benefit from primary prevention strategies, including guideline-directed medical therapy, some of the 4 pillars, such as SGLT2 inhibitors, ARNIs, ACEs, ARBs, beta blockers, and aldosterone antagonists, all aimed at preserving cardiac function without interrupting effective cancer therapy.
Thank you so much, Dr. Mysore. That was such a great overview, and I think the key takeaway for me is that for a patient like Ms. Adriamycin, who's already at fairly high cardiovascular risk, we don't rely on a single snapshot of heart function. Instead, certainly it's important for us to be following trends over time so that we're able to identify myocardial injury as it shows up in labs, or perhaps strain on the echo, which certainly may happen well before the ejection fraction drop happens. And I really appreciate that there's so much emphasis again on following trends so that we're able to address any concerns right away and allow for our patients to be hopefully maintained on this life-saving chemotherapy as best as possible, while certainly addressing its effects in terms of heart failure with the appropriate guideline-directed medical therapy. Risk stratification is certainly crucial when it comes to prevention of CTRCD. Dr. Mysore, what are some risk factors in general that we need to think about when we're looking at CTRCD development? And how would you stratify our patients' risk?
That's an excellent question. And it goes into many risks per se. And of course, risk stratification is indeed central to preventing cancer therapy-related cardiac dysfunction. There's probably about 2 main categories, one where you focus on the patient and the other you focus on the therapy. Patient-related risk factors include old age, pre-existing cardiovascular disease such as heart failure, coronary artery disease, hypertension, diabetes, obesity, and probably prior arrhythmias. Therapy-related factors involve high cumulative anthracycline dose, combination therapy potentially with other agents such as trastuzumab, prior chest radiation, and even certain novel agents such as tyrosine kinase inhibitors or even immune checkpoint inhibitors. For Mrs. Adriamycin, she has several patient-related high-risk features, including HFpEF, hypertension, diabetes, obesity. She's also about to receive anthracycline chemotherapy, which is a classic cardiotoxic agent. Taken together, she falls into a very high-risk category for CTRCD, which means we'll need close monitoring, proactive use of cardioprotective strategies, and early intervention if any cardiac changes appear.
Well, it's a busy day here at the CardioNerds Cardio-Oncology Clinic, so let's move on to our next patient. Ms. Hera 2 is a 52-year-old woman with HER2-positive breast cancer who's completed her anthracycline therapy and is now on trastuzumab. During a routine surveillance echo, her left ventricular ejection fraction is found to have dropped from 60% to 45%. She reports mild dyspnea on exertion, orthopnea, and paroxysmal nocturnal dyspnea. She is worried about the recent change in her heart function and is interested in starting cardiac medications. Dr. Mysore, what are some of the current management recommendations for heart failure, cancer treatment-related cardiac disease? What role does GDMT have?
Great question. This is a classic teaching case in cardio-oncology. Ms. Hera 2 meets criteria for symptomatic CTRCD, as she's had a significant drop in EF to below 50% and clear heart failure symptoms after anthracycline exposure, as well as during trastuzumab therapy. The key teaching point is that we don't manage this differently necessarily from standard heart failure. Guideline-directed medical therapy is the backbone of the treatment, and that means early initiation, ARNIs, ACE inhibitors, ARBs, plus an evidence-based other medications include beta blockers, because these medications are both associated with LV recovery and prevention of further decline in LV ejection fraction. Diuretics may be used for congestion, but they don't necessarily modify disease process or play a significant role in structural remodeling. And if the EF remains reduced or symptomatic, adding other agents such as corticoid receptor antagonists such as spironolactone or eplerenone, and increasingly SGLT2 inhibition is very reasonable and safe in cancer patients. From a cancer therapy standpoint, in someone who is symptomatic with an EF less than 50%, guidelines support temporarily holding trastuzumab, starting GDMT promptly, and reassessing ventricular function in 4 to 6 weeks. This really important takeaway for trainees is that trastuzumab-related cardiomyopathy is often reversible with early intervention, and timely GDMT can allow patients to safely resume life-prolonging cancer therapy. It's also worth highlighting the data on early preventative therapy. Smaller randomized trials such as PRADA and CCCY or CESI show that initiating an ACE inhibitor or beta blocker during anthracycline therapy can modestly reduce declines in LVEF. And Manticore suggested a similar signal with neurohormonal blockade during trastuzumab treatment, particularly in limiting adverse remodeling. The SAFE Heart study further demonstrated that patients with mildly reduced EF could often safely continue HER2-targeted therapy when managed with close surveillance and guideline-directed medical therapy. That said, these studies were largely underpowered for heart outcomes, so while early introduction appears beneficial for preserving EF, we still need larger randomized trials in high-risk populations to definitively show reductions in overt heart failure events. For now, the strongest evidence remains for early GDMT once dysfunction is detected, with preventative strategies considered on a case-by-case basis.
It sounds like symptomatic CTRCD has the same management as standard heart failure with GDMT. And there actually may be a role for holding the chemotherapy agent and also consideration of starting that GDMT earlier during the chemotherapy regimen. Now, Ms. Hera 2 returned 3 months later. She's been reading a lot of health news articles, and she recently read about SGLT2 inhibitors and their anti-inflammatory effects. She's interested in finding out more about these medications and if they may be useful in her case. Dr. Mysore, can you explain the mechanism of action of SGLT2 inhibitors and what their use is in the world of cardio-oncology?
Wonderful question. It's something that patients read about newer medications such as SGLT2 inhibitors. At their core, these drugs work by blocking the sodium glucose cotransporter 2 in the proximal renal tubule, which leads to increased urinary glucose and sodium excretion. That renal effect drives a cascade of downstream benefits: reduced preload and potentially afterload, improved ventricular loading conditions, and better heart failure outcomes, independent of diabetes status. In cardio-oncology, what's especially interesting is that their benefit seems to extend well beyond hemodynamics. SGLT2 inhibitors promote metabolic reprogramming of the myocardium, shifting fuel utilization towards beta-hydroxybutyrate, which is more oxygen-efficient substrate and improves mitochondrial function, something that's relevant in the heart when stressed by chemotherapy. It also has meaningful anti-inflammatory and antioxidant effects, dampening key cytokines such as IL-1, IL-6, TNF-alpha, and suppressing the NLRP3 inflammasome activation, which is increasingly recognized as a contributor to cancer therapy-related cardiac dysfunction. On the vascular side, SGLT2 inhibitors reduce endothelin-1 signaling, limiting vasoconstriction, fibrosis, and adverse remodeling. And intriguingly, there's emerging preclinical and early translational data suggesting that some tumors express SGLT2 transporters, raising the possibility that these agents may impair tumor glucose uptake and even enhance chemosensitivity. While that anti-tumor signal remains exploratory from a cardiovascular standpoint, SGLT2 inhibitors are now a core component of heart failure therapy and are very reasonable in cardio-oncology patients like Ms. Hera too, given their safety, lack of interaction with cancer therapies, and multifaceted cardioprotective effects.
Wow, this has been such an incredible discussion so far. We've learned so much about what CTRCD is, what are the risk factors that we need to look out for, how do we diagnose it, and how do we treat it with the arsenal of some of our traditional heart failure GDMT medications. And certainly we're just starting to focus on the superstar of the show, which are the SGLT2 inhibitors. Dr. Mysore, I would love to delve deeper into exploring the role of SGLT2 inhibitors and understand some of the data surrounding their use in the cardio-oncology world. And to kind of help frame the discussion further, I'd like to talk about our third patient. Our third patient is Ms. Azukar. She is a 68-year-old woman with a long history of type 2 diabetes, A1C of 8.2%. Other past history includes hypertension, stage 3A CKD, and she was recently diagnosed with stage 3 triple-negative breast cancer. She is about to start anthracycline therapy, and during her pre-chemotherapy evaluation, she mentions that she saw a pamphlet at a local health drive about research on heart protection. She asks if her, quote, sugar pill could actually serve a dual purpose by protecting her heart during her cancer treatment. Dr. Mysore, is there any role for SGLT2 inhibitors in primary prevention?
It's a great question, especially because this is a primary prevention scenario, which is very different from our prior patients with established heart failure. Mrs. Azukar is actually a classic high-risk cardio-oncology patient, longstanding diabetes, hypertension, stage 3 CKD, and now planned anthracycline therapy. Mechanistically, SGLT2 inhibitors are very attractive, but when we look at the clinical data, we need to be honest about where the evidence comes from. There are currently no large randomized trials specifically designated to test SGLT2 inhibitors for primary prevention of anthracycline-related cardiomyopathy. However, we do have strong indirect evidence from large cardiovascular outcome trials in diabetes. Studies like EMPA-REG, Outcome, Canvas, and Declare TIMI 58 consistently showed significant reductions in heart failure hospitalizations and slowing of kidney disease progression, even in patients without baseline heart failure. More recently, heart failure trials such as DAPA-HF, EMPEROR-Reduce, and DELIVER demonstrated benefit across the spectrum of ejection fraction, reinforcing that these effects are not necessarily glucose-dependent. In the cardio-oncology space specifically, emerging retrospective and real-world analysis suggests that diabetic patients receiving chemotherapy who were on SGLT2 inhibitors had lower rates of heart failure events and less LVEF decline compared to those other glucose-lowering agents, though these data remain observational and hypothesis-generating. So the key teaching point is this. We would not necessarily start an SGLT2 inhibitor solely for cardioprotection during chemotherapy just yet, but in a patient like Ms. Azukar, who already meets strong guideline indications because of her diabetes, CKD, and cardiovascular risk, initiating or even continuing an SGLT2 inhibitor is very reasonable and may provide a meaningful dual benefit during cancer treatment.
So it seems that the retrospective data is highly suggestive of the benefit of SGLT2 inhibitors, particularly in patients with diabetes or high cardiovascular risk. I know you mentioned that randomized clinical trials haven't been performed, but are there other kind of prospective studies that we should be aware of and have on our radar?
Yes, there are a few that are probably going to result shortly or have some portion of their results already published. The most notable step forward was EMPA-CARD pilot trial published in 2024, which specifically looked at empagliflozin for the prevention of AIC or anthracycline-induced cardiotoxicity. In this randomized trial, empagliflozin was associated with a significant reduction in CTRCD at 6 months, with an 82% relative risk reduction compared with controls. And importantly, patients in the empagliflozin arm had preservation of LVEF, whereas controls experienced the expected decline. While this was a pilot study and not powered for long-term clinical outcomes, it presents a critical proof of concept that SGLT2 inhibitors may offer true cardioprotection in the anthracycline setting. The key teaching point is now we're moving beyond observational signals into early prospective evidence, and larger definitive trials are still needed before broad guidelines are endorsed. EMPA-CARD pilot develops a strong rationale for continued investigation of SGLT2 inhibitors as a primary prevention strategy in high-risk cardio-oncology patients.
That's powerful data and very exciting prospective studies that are being currently conducted. Mrs. Azúcar actually saw some ongoing trials that were mentioned at a pamphlet at a recent local health fair that she went to, and she's interested in possibly participating in one of these trials, but she wants your opinion first. Could you tell us about any ongoing trials that are currently going on?
It's great that Ms. Azúcar is asking about clinical trials because this is exactly where the field is headed. There are several important ongoing prospective studies looking specifically at SGLT2 inhibitors for the primary prevention of cardiotoxicity. One key trial is called IMPACT, a double-blind randomized placebo-controlled study evaluating empagliflozin for the prevention of cancer therapy-related cardiac dysfunction in patients receiving anthracyclines. In parallel, there are 2 dapagliflozin-based trials worth highlighting. PROTECT-AA, studying dapagliflozin in patients undergoing anthracycline-based chemotherapy, while the PROTECT trial expands that question further by including patients exposed to both anthracyclines and trastuzumab, which reflects real-world breast cancer treatment pathways. The major teaching point about this is that these trials are designed to move the field from promising observational data to definitive evidence that can inform guidelines. For motivated high-risk patients like Ms. Azúcar, participation in these studies not only offer close cardiovascular surveillance, but also help answer one of the most important unanswered questions, such as whether SGLT2 inhibitors could become standard therapy for cardioprotection during cancer treatment.
It's really awesome to hear about all of these ongoing trials, and it speaks to how this field is certainly evolving very, very rapidly. And what's particularly encouraging about hearing about all of this is the aspect that we're moving now from a focus of treating cardiotoxicity to perhaps focusing more on preventing it in the first place. So with that, we'll move briefly to preclinical data. Dr. Mysore, what have mechanism studies shown regarding SGLT2 inhibitor protection against specific cancer therapies?
Certainly. So looking at some of the preclinical data, several studies have given us a clearer picture of how the SGLT2 inhibitors protect the heart against cancer therapies, especially at a mechanistic level. For anthracyclines, dapagliflozin and empagliflozin have both shown in murine and large animal models to preserve LV systolic and diastolic function by reducing cardiomyocyte apoptosis, attenuating reactive oxygen species production, and suppressing inflammatory cytokines such as IL-1 beta, IL-6, and TNF-alpha. They also inhibit the NLRP3 inflammasome activation and decrease further myocardial fibrosis, which together limits remodeling and preserves contractile function. For HER2 therapy, dapagliflozin has preserved cardiac function in mice exposed to sequential HER2 blockade and doxorubicin by enhancing mitochondrial efficiency, maintaining ATP production, and reducing oxidative stress, suggesting a mitigation of early dysfunction from combination therapy. And in the case of other novel agents such as tyrosine kinase inhibitors like sunitinib, for example, empagliflozin has improved sunitinib-induced cardiac dysfunction by normalizing LVEF, reducing systolic hypertension, and modulating endothelin-1 signaling, which limits vasoconstriction and added myocardial stress. Taken together, these studies highlight that SGLT2 inhibitors act via metabolic reprogramming and have anti-inflammatory and antioxidant effects, also have antifibrotic signaling, and provide vascular modulation, further providing compelling mechanistic rationale for their cardio-oncology benefit across multiple cancer therapies.
Our final clinic patient today is Mr. Checkpoint Alpha, a 60-year-old male with metastatic renal cell carcinoma. He's currently on dual immune checkpoint inhibitor therapy with an anti-PD-1 and anti-CTLA-4 therapy. He's currently oncologically stable and asymptomatic, but he is a proactive patient who has been reading about the potential for fatal myocarditis associated with immune checkpoint inhibitors. He wants to know if SGLT2 inhibitors, which we heard are heart failure staples, have any role in preventing or managing these unique toxicities. While we've discussed traditional chemotherapy, the landscape of immunotherapy presents an entirely different challenge, like ICI-induced myocarditis. Dr. Mysore, for a patient like Mr. Checkpoint Alpha, is there any emerging role for SGLT2 inhibitors in the setting of ICI therapy, maybe leveraging their anti-inflammatory and antioxidant effects?
Great question. Mr. Checkpoint Alpha brings up an excellent and increasingly relevant point regarding immune checkpoint inhibitors, such as nivolumab and ipilimumab, which are associated with a unique form of cardiac toxicity, ICI myocarditis, which is rare, but can be fulminant and even fatal. Mechanistically, this is quite different from anthracycline or HER2-related cardiomyopathy because it's driven by immune activation, T-cell infiltration, and cytokine-mediated myocardial injury rather than direct oxidative stress or metabolic derangements. That said, the anti-inflammatory, antioxidant, and metabolic effects of SGLT2 inhibitors are theoretically appealing, where preclinical studies have shown that they can reduce IL-1, IL-6, TNF-alpha, and the entire NLRP3 inflammasome activation, thereby improving mitochondrial efficiency, effects that in theory could modulate the inflammatory cascade in ICI myocarditis. However, it's critical to emphasize that there's no current clinical trial or prospective data supporting the use of SGLT2 inhibitors for the prevention or treatment of ICI-induced myocarditis. So while these drugs are cornerstones for heart failure management and show promise in traditional cardiotoxicity, their role in ICI-related immune-mediated cardiac injury remains purely hypothetical, and the safest approach for patients like Mr. Alpha remains early recognition, clinical suspicion, EKG monitoring, and rapid initiation of suppression if myocarditis develops, while continuing standard heart failure therapies if indicated.
We've discussed a lot of promising studies and ongoing clinical trials looking at SGLT2 inhibitors and their potential cardioprotective role in CTRCD. But Dr. Mysore, what are some critical gaps that you would like to see future research address?
Yeah, there are several gaps that would be vital to the field to study. First, we need larger prospective randomized trials specifically powered for cardiac endpoints, not purely LVEF changes, but also looking at mortality, heart failure hospitalizations, etc., especially in patients receiving anthracyclines, HER2-targeted therapy, or a combination of both. Second, the optimal timing, dosing, and patient selection for primary prevention are still unclear with a lot of subjectivity. Should SGLT2 inhibitors be started before therapy in all high-risk patients or only after signs of dysfunction? Third, there's limited mechanistic understanding in humans. While preclinical studies show anti-inflammatory, antioxidant, metabolic, and antifibrotic effects, it's not clear which pathways are most relevant for cardiac protection in patients. We also don't know the long-term safety and efficacy of these drugs in the cancer population, especially regarding interactions with chemotherapeutic agents that continue to expand. Finally, for emerging therapies like immune checkpoint inhibitors or tyrosine kinase inhibitors, it remains unknown whether SGLT2 inhibitors can prevent or mitigate these distinct immune-mediated cardiac toxicities. Addressing these gaps will be essential to translating the strong preclinical and early clinical signals in evidence-based guideline recommendations.
This has been such an incredible discussion with so many practical clinical pearls. As we wrap up, what would you say are the key takeaways that you'd want our CardioNerds audience to remember?
Today, we dove into the exciting role of SGLT2 inhibitors in cancer therapy-related cardiac dysfunction. CTRCD can range from subclinical injury detected by imaging and biomarkers to overt heart failure, and the risk is highest in patients with pre-existing cardiovascular disease and other risk factors including diabetes, hypertension, obesity, exposure to anthracyclines or HER2-targeted therapy or radiation, and likely even more. Traditional guideline therapies, including ACE inhibitors, ARBs, ARNIs, beta blockers, MRAs, remain the backbone for prevention and treatment, and early initiation is key to preserving LVEF and safely continuing cancer therapy. SGLT2 inhibitors are emerging as a powerful adjunct, acting via renal effects, metabolic reprogramming, anti-inflammatory and antioxidant pathways, and vascular fibrosis modulation. Preclinical and pilot clinical data, including the 2024 EMPA-CARD pilot trial, has shown preserved LVEF and reduced CTRCD in high-risk patients with diabetes or kidney disease. Ongoing trials like EMPA and IMPROTECT are exploring their role in primary prevention during anthracycline and HER2 therapy. For ICI-related myocarditis, the mechanism is immune-driven, and while SGLT2 inhibitors have theoretical anti-inflammatory benefits, there are no clinical evidence yet to support their use in this setting. Critical gaps remain, and as such, we need large prospective trials, clarity on timing and patient selection, long-term safety, and further mechanistic understanding in humans. Bottom line is that SGLT2 inhibitors are a promising new pillar of cardioprotection and cardio-oncology, complementing standard therapies, but their use should be guided by patient risk, existing indications, and of course, ongoing research.
Thanks so much, Dr. Mysore. That was a really wonderful summary filled with so many pearls. One thing we would love to know is what makes your heart flutter about cardio-oncology?
So what makes my heart truly engaged in this field is just the weight and impact of the work. You really sit at the intersection of life-saving cancer therapy and long-term cardiovascular health. Decisions influence whether a patient can complete treatment safely, avoid heart failure, maintain quality of life. I'm drawn to the challenge of anticipating, preventing, and mitigating cardiac injury while supporting effective cancer care. It's a space where precision medicine, monitoring, and multidisciplinary collaborations come together to protect patients without compromising their fight against cancer. And that responsibility is indeed humbling and, of course, deeply motivating.
Well, on behalf of all the cardio nerds around the globe, we want to thank you, Dr. Mysore, for your expertise. I have personally learned so much about SGLT2 inhibitors in CTRCD. I also want to thank Shivani for all of her hard work developing this podcast, and Rebecca for her leadership on our corresponding review article on the cardioprotective role of SGLT2 inhibitors in CTRCD. Thank you to all of our amazing Cardio Nerds listeners. Be sure to check out our detailed notes and references, including the relevant ESC cardio-oncology guidelines. For an added primer on CTRCD, please check out episodes 261 and 274 from the CardioNerds Cardio-Oncology series.
Thank you so much for tuning in to this CardioNerds episode. The audio editing for this episode was performed by me, Julia Marques. I am an intern in the CardioNerds Academy House Taussig, and I'm a 6th-year medical student at Albert Einstein University in São Paulo, Brazil. Check out the episode page for show notes and references. If you found this episode or the show informative, please consider subscribing to CardioNerds on your favorite podcast platform and leaving us a review. It really helps us spread the word and further our goal to democratize cardiovascular education. Finally, this podcast is not meant to be used for medical advice. The views expressed on our show and site do not reflect the opinions or policies of our employers. All CardioNerds content is planned, produced, and reviewed solely by CardioNerds. Stay tuned for more engaging conversations and explorations in our new and exciting upcoming episodes. And now, my friends, it's time to make like an S2 and split.